Welcome back, and thank you for joining the Fielding School of Public Health Continuing the Conversation webinar. Does income inequality have a differential effect on types of health services? Does a community's social capital mitigate the potential health penalties of structural inequities? These are some of the questions that Dr. Ninez Ponce will address in today's webinar, Examining Social Determinants and Health. Dr. Ponce, who helped develop the first California Health Interview Survey, will examine the effects of income inequality, racial, ethnic composition, and residential segregation on healthcare to determine whether these social processes lead to structural inequities and undermine the productivity or distribution of medical care and ultimately erode population health. We want this to be a dialogue, so we will allow plenty of time for questions. If you have a question, simply type it in the field at the bottom of the chat window in the bottom left-hand corner of your screen. Let's get started. Dr. Ponce.
Thank you, Karen. I'm very happy to be here, and I'm very privileged to be part of several communities at UCLA. First and foremost, my home department, the Department of Health Policy and Management at the UCLA Fielding School of Public Health. I'm also part of the UCLA Center for Health Policy Research and Associate Director of Asian American Studies Center. So today I'm going to, my presentation is divided into three parts. First, it will be an introduction on what we're talking about when we're talking about social determinants of health. And I draw on policy frameworks largely submitted and put forth by the World Health Organization and Robert Wood Johnson. And then we're going to talk about specific mechanisms and pathways, and end the presentation, the discussion, on a call for policy action and how it interfaces with the Affordable Care Act. So what are social determinants of health? It's basically what you see, what we hear, what we sense about people's lives. It's also about how they access their health care, and this could be related to the quality of their schools, their education, the conditions where they work, where they play, their homes and their communities, and their hopes and opportunities of leading a flourishing life. An important mirror of social determinants of health is this notion of structural inequities. And structural inequities, as WHO Commission on Social Determinants of Health defined it as the distribution of power, of income, of goods and services, both globally and nationally. Inequity is associated with ill health. This picture here of my hometown, San Francisco, in all its glory, and another town, actually somewhere in the Midwest where my husband is from. Globally, up to half of all ill health can be explained in terms of differences between the most advantaged persons or groups compared to the most disadvantaged. And in this next slide here, where it shows the policy framework by the World Health Organization, the next slide shows how the socioeconomic and political context, and that would be the orange L part of this slide, and how this is connected with the intermediary determinants of health, and how then that impacts equity in health and well-being. I'm going to try one of these here. So the socioeconomic political context, which includes governance, macroeconomic policies such as tax policies, minimum wage policies, social policies, public policies in education, health, social protection, and culture and societal values, then these would be considered the structural determinants of health inequities. The structural determinants of health inequities then are part and parcel to individual characteristics of social determinants: an individual's socioeconomic position, their social class, their gender, their ethnicity, their level of education, occupation, and income. And then this then flows into the material circumstances of where they live, where they work, in addition to their behaviors and some biological factors and psychosocial factors. What is key here is that the health system is a tiny part of this overall conceptual framework. It's a tiny part in determining what the impact is on equity and health and well-being. And so that, again, globally and nationally, all of the other context, the socioeconomic political context, has a large, explains a large of possibly what the differences are in health outcomes. This framework is another framework by Robert Wood Johnson Foundation on a commission to build a healthier America. This framework, what's nice about this framework is it shows how medical care and personal behavior, so this area here would be more at the individual level, the black arc, and this semicircle, and then the gray, so the individuals are nested within their living and working conditions, this gray semicircle here, and then nested in this macroeconomic policies of economic and social opportunities and resources. Again, medical care is a part of this conceptual framework. It is largely at the individual level and not so much expressed from the economic and social opportunities and resources. So these conceptual frameworks are just try to show some linkages between social determinants of health, between social determinants and health care. But the linkages aren't completely or clearly understood. Part of it is that the sources of social determinants of health occur over time and space, very difficult to measure, so that tracking exposures over a lifetime across different places where the individual lives and works and moves in different areas then presents a major data challenge. The factors are also difficult to observe, such as how well an individual copes with social stressors, how well an individual harnesses the assets in their neighborhood that modifies the extent that the social determinants of health impacts their health. There's also mediating factors that link social determinants with health. So mediating factors here could be the availability and quality of health care that may link the relationship between social determinants of health and health. This has to be better understood to inform the formulation of health policies. What I'm proposing is changing the lens on inequities and healthcare and an alternative approach. A lot of what's understood or still where the evidence is building is more on how inequities affect health. Fewer studies, there's less evidence on how inequities affect healthcare, how social determinant inequities affect healthcare. So this alternative approach is elaborating then on how structural determinants affect the organization and delivery of health services based on our assumption that the health system mediates the linkage of the social determinants of health with health and health inequities. I propose that the structural inequities could do harm in two ways. So first is allocation. Structural inequities determines allocation on who gets quality health care and who does not. So that would translate into differential access. Second is that structural inequities could undermine the productivity of medical care inputs. Well, is this a big deal? So Sandra Galileo quantified how area level inequities could contribute to deaths. And in his study, nearly 3 decades worth of evidence implicating social factors in the production of health and health inequities, he's examined 47 studies in the US from 1980 to 2000. And the death toll attributed to specific social factors were comparable to the number of deaths caused by acute myocardial infarction, cerebral vascular disease, or lung cancer. So neighborhood poverty, income inequality, and racial segregation, all told with number of deaths, were comparable to those to the leading causes of death in the US today. So now we're going to go into the mechanisms and the pathways. Because the U.S. is inherently unequal, contextual social determinants lead to structural inequities in health and in health care. Many agree globally and in the U.S. that the most consequential social determinants are the ones that generate stratifications in social position that advantage some individuals in income, social status, political power, or favorable environmental exposures and assets, but disadvantage others. For this reason, I'm going to focus on area level or community level measures, not individual measures, but area level, community level measures. The 5 mechanisms we'll discuss today are area-based income. The second is income inequality, racial ethnic composition. The 4th is residential segregation, and the 5th is social capital. Area-based income. Higher income areas could attract a greater supply of healthcare providers. And a greater supply of healthcare providers then could lead to more competition. And more competition then presumably could lead to higher quality of care. So area-based income then could, this is one mechanism of how area-based income could lead to differential, to the differences we see in different areas on quality of care. Higher income areas with also have lower unemployment rates, and they may also offer more options for health insurance. So the residents of higher income areas then would be better insured and would have better access to care. Areas with greater household incomes also may be able to better support safety net services because, for example, they have higher real estate taxes to support county hospitals. And so they may be able to support other types of policies that can alleviate disparities in care. They could support a safety net. I'm also happy to entertain questions as I go along here. The second area level stratification measure is income inequality. In addition to overall area level income, the distribution of income and wealth within an area can also influence the delivery of health services. Income inequality, typically measured as the Gini index or Gini coefficient, where 0 indicates the most equal income distribution and 1 the most unequal, is actually at an all-time high in the U.S. and is one of the highest among similar economies. Although evidence from different countries is mixed on whether or not the gap between the rich and poor erodes the health of populations, the findings on income inequality's negative effect on health, typically measured as mortality or a self-rated health is most robust for the United States. And among studies that do find an effect between income inequality and health, across all nations, income inequality appears to be most detrimental to the poor. In health services, on the supply side, areas with high income inequality could attract specialists who are more likely to be located near academic centers and thus favor the use and diffusion of expensive specialty care. With income inequality suggests that there's a difference or there's a divide in social position, so that clinicians may differentially value patients owing to the provider's perceived hierarchies by class, by gender, and by race. And another mechanism on the demand side is that for low-income patients, income inequality may stigmatize patients and lessens their agency, lessens their ability to optimize the patient-physician encounter, to ask for certain tests, for example. Excuse me, Eric, I'm stuck. Okay, got it. Okay. All right. There are a few studies on income inequality on healthcare. However, there's no clear understanding of the direction of income inequality's effect on healthcare. A study by Clark West in 2008 showed that higher state-level income inequality was associated with poorer healthcare quality, based on measures of average adherence to about 22 Centers for Medicare and Medicaid Services quality of care measures, and found that healthcare quality does indeed mediate the negative association between the Gini index and life expectancy. However, another study found that income inequality is only weakly associated with maldistribution of doctors and not associated with hospital bed distribution. So the evidence for the United States is still mixed. The third stratification measure is area-based racial and ethnic minority composition. Studies of individual-level health, racial, and ethnic disparities have focused on mechanisms such as experiences of discrimination that the patient perceives from receiving health care, the lack of cultural competency among providers or healthcare systems to accommodate diverse population needs, and some studies have looked at, although it's been mixed, on that potentially some disparities could be because of racial and ethnic discordance between the patient and the physician. And that discordance could then lead to this lack of cultural competency and discrimination. The studies of area-level disparities have not delineated a specific mechanism for community-level racial and ethnic-based inequities. However, part of it could be the measurement at what level. Recent literature has argued by Gaskin that compositional measures such as racial and ethnic minority composition, the percent, for example, percent non-minorities, percent whites, percent Latinos in a neighborhood, may not capture the effects of community context, because it is a level measure, not a distribution measure of resources within an area. So not the average level, it's not the average level that drives the disparities in access to care, but the distribution. So then turn to the fourth measure, which gets a bit at the dynamics of this distribution, racial, ethnic, residential segregation. And in this measure, the isolation of disadvantaged groups into concentrated neighborhoods is associated with poor education systems, employment opportunities, access to transportation, and public safety. However, Hispanics and Asian communities have lower odds of experiencing physician shortage, and formation of Hispanic and Asian ethnic enclaves may offer benefits of social networks with improved access to information and providers. So again, the evidence is mixed here. If segregation is a plus or a minus, segregation could lead to, again, increasing the disadvantage, but for some newer groups, new immigrants where social ties are especially important for the gateway communities like ethnic enclaves, that it actually might be promotive of health. This is a measure of community residential segregation. It is different from racial ethnic composition. Again, it's a measure that tries to get at the dynamics of an area. A common measure of residential segregation is something called the dissimilarity index, proposed by Massey and Denton. It's the degree to which two or more groups live separately from one another in a different parts of an urban environment. This is usually measured at the city level, possibly at the county level, and it would be showing how a group would have to move to have an even distribution. So the higher the index, the more segregated a community is. And one note is that this measure is only good for two group comparisons, not for multiple group comparisons. So you could look at whites versus blacks, Latinos versus non-Latinos, but you wouldn't be able to look at, say, for example, Latinos and Asians and whites in such a measure. So in summary, for income inequality, there appears to be a differential effect by type of health services, even though the evidence isn't enormous and it's a little bit mixed, but there seems to be consistent evidence that a more egalitarian space is associated with more primary care and the safety net services. However, it's not associated with specialty services or more expensive services. For racial ethnic residential segregation, it's negatively associated with a host of health services supply, with physician visits, primary care physician supply, ambulatory surgical facilities, supply of general surgeons, subspecialists, and there's also evidence, though, of positive enclave effects. And perhaps that could be explained by social capital. It's the next measure I'll talk about. So this notion is the fifth measure of an area-level social determinant of health, social capital. Bob Putnam refers to this as all the features of social life, networks, norms, trust, that enable participants to act together more effectively to pursue shared objectives. The notion is that greater community social capital, which could occur at many levels, at the nation, the state, and neighborhoods, would be positive, would have a positive effect, and would be linked with improved health outcomes. Some of the studies that have linked this positive effects being linked to self-rated health. The question of, in general, is your health, excellent, very good, good, fair, poor? It's been linked to positive health-related quality of life, the number of physically and mentally healthy days that you've had over the last 30 days. And it's been related to lower rates of all-cause and disease-specific mortality. So community social capital is thought to facilitate then access to care through information flows, how connected you are to your neighborhood, how supported you are in neighborhoods. So for example, somebody will watch your kids when you go seek health care or go to your annual exam. It improves relationships also between residents and healthcare providers. And the mechanism of that is that community social capital has been strongly associated with increased trust and healthcare providers. However, there is mixed evidence on measures on access to care. There are positive linkages, having a regular source of care, increased use of mental health services, a recent study on higher likelihood of children's access to a patient-centered medical home. But it also could be associated with fewer visits to a general practitioner, higher number of preventable hospitalizations, some preliminary work I'm doing on a lower number of preventive cancer screening tests. So I think the controversy with social capital is that that even though interventions that promote community formation are important, they are necessary, they are not sufficient. So the policy space that addresses building and developing community-level social capital is not enough. And in some ways, it's been criticized that focusing on this might shift government attention, so that you still need government-level attention in macroeconomic and social policies that reduce the structural inequities because of the inherent inequities in the United States on where people live and work. And so I'm moving to the last part for a call for policy action and interface with the Affordable Care Act. The Affordable Care Act, I think this is continuing the conversation. I'm sure there's been lots of conversations about the Affordable Care Act. The start date is this coming January, open enrollment this October. The Affordable Care Act, or ACA, its purpose is to improve access, affordability, and quality of care. It includes provisions to improve equity. So I wanted to highlight that. There's language in the Act that stresses that policy should fit the local context and that engaging stakeholders are a must. The interface then with health reform policy action is that the ACA acknowledges that inequities in health and healthcare are beyond the healthcare system, and that it's largely a product of social, economic, and geographic inequalities. So the ACA incorporates strategies that span not just the health sector, but multiple sectors of the economy and federal government to improve overall community infrastructures and population health. There are some policy levers that could enhance the ACA, labor markets and tax policies, social and public policies in education, housing, employment, and social welfare. All not in the language of the ACA, but certainly in the language that addressing these social and economic and geographic inequalities would certainly optimize the policy goal of the ACA. This slide just shows specific sections in the ACA that have social determinants of health provisions. I won't go through each one. I believe there's also some, Dr. Fielding maybe in the next conversation will detail some of this. The health impact assessments, the review recommend intervention social context, which I'll talk about in another slide, community transformation grants, which do come with money, nonprofit hospital community needs assessment, and primary care extension program. There's also a data collection provision in the ACA. It's section 4302 that's not explicitly cataloged as a social determinant of health provision, but I submit it definitely is. It's language that requires national population health surveys to collect data on race, ethnicity, primary language, disability status, and gender. This is important not just for national surveys like the National Health Interview Survey or the Medical Expenditure Panel Survey. It's absolutely important for states and local areas who have population surveys to also collect this, since states are running both the Medicaid programs and the exchange. I'm happy to say that in California, for the California Health Interview Survey, we are collecting all of this. Population-based data is needed, so the CPSTF that I referenced in the previous slide, actually chaired by Dr. Fielding, is tasked with developing topic areas for new preventive interventions that consider social, economic, and physical environments of communities. It also authorizes the task force to review the health effects of interventions at least once every 5 years, and requiring population-based data to do the health impact assessments. It also encourages primary care physicians and providers to address social determinants through community-based efforts. So one example is for enabling services in community health centers, enabling services that deal with transportation, with interpretation, for example, are necessary services to enhance the patient experience, and this is encouraged into the ACA. So what are some specific policy actions that I would suggest? I think we should incorporate social determinants of health as incentives in the provision of care. For example, incorporating social determinants of health in risk adjustment for fair payment to providers would be important, especially for providers with care to medically underserved population. And so this is important, for example, with the exchange, where you'll have a blended population of newly insured who are under 40% poverty level, blended with those who have been traditionally commercially insured, that perhaps incorporating the social determinants of health could compensate providers that see more complex medically underserved patients fairly. Medicaid and state health insurance exchange could also reimburse for these enabling services that address social determinants of health, services that deal with interpreter services, transportation, health literacy. And of course, better data. Better data need linkage of individual level population data that measures social determinants of health with administrative data on the supply and location of providers, community health centers and hospitals, and other data systems. And certainly the allocation to improving electronic health records would be one impetus in getting better data and accelerating this. I end with food for thought about social determinants of health and the ACA. The ACA is a landmark law. It assumes that coverage will reduce the financial access-based healthcare inequities, and it's very important. My worry is that as resources are directed to spread coverage for nearly all the U.S. populations, of course with 5-year bars, immigration status limits, that more expensive health services may be rationed on the basis of social determinants. So identifying then which social determinants matter more or less in which communities on specific health and healthcare inequities post-ACA, I think would be instructive in formulating the social policies and public policies in other sectors. And I think by doing this, we could better fulfill the policy goals of the ACA. Thank you.
Hello?
Oh, I'm having audio system. Hello, sorry, I had an audio error. Hi, Karen.
Okay. Let me repeat the question. Under the Affordable Care Act, do you think income inequality and residential segregation matter more or less in accessing expensive care, tests, and procedures, especially for the poorest and for vulnerable racial ethnic minorities?
Thanks, Karen. I think I think that gets the gist of my argument. I think it depends. I think if it's preventive services, if it's less expensive services, that it would alleviate the access inequities that we've had. However, I think that again, if the rationing is just based on social determinants, meaning like it's some individuals may not be able to have access to the types of providers that they need, then I think that it could, or the tests, more expensive tests, then I think it could exacerbate the disparities. But I think it's something that we need to study more.
Thank you. And how should we intervene to improve health and reduce health inequities? At which levels?
That's a big question. I'm arguing that it should be at multiple levels. I think, that it should be both, not just at the level of the individual, which would be interventions, for example, as health behavioral interventions, but also with the communities that they live, so with community level interventions. And then, of course, voting for the types of income tax policies that perhaps could be more progressive.
Thank you. If you have a question to the participants here, please type it in the chat window on the lower left of your screen. I have one last question. Can you comment how ethnic enclaves might be beneficial to new immigrants?
I think that for new immigrants, they're living in ethnic enclaves. It provides language matches. People could communicate in their home country language. Ethnic enclaves could have food stores and commercial areas that are very connected to home country goods and services. So I think it provides a sense of social cohesion, a sense of social support for new immigrants. So it could be so this kind of trust then could lead to support in accessing health services, but that's not enough. Again, I think there has to be interventions both of ensuring that there are accessible providers in an area, providers in ethnic enclaves that would signal, for example, the importance of cancer screening tests, that would signal the importance of preventive services. So a supportive environment can facilitate time to go get healthcare services, but you still need that investment from the healthcare sector to ensure that there aren't any access differences.
Thank you.
I see, Karen, thank you. I see a question. Shall I read it, Karen?
Yes, please, so I can read it. What are your, Isabel Letts is asking, what are your thoughts on existing measures for social determinants of health? Do we need more research to improve measures, or do we need more studies to test existing measures?
That's a really, really good question. I think we need to do both. I focused on area level measures on social determinants of health. There are also individual level measures, and individual level measures, for example, would be income, education, wealth, as well as gender, health literacy. So there are individual level measures, and even just measures of wealth alone is controversial. Measures of income is controversial. So there's certainly room for improvement for individual level measures. Area level measures are, I went through 5 different measures, and they could be looked at as measures that are percentages or averages, say, of a certain area, or measures that get at the distribution of the area. So I think each one tells a different story, and each one, and then the story is also different depending on what the outcome is. But I am proposing that I really think what's behind that conceptual framework that I went over from the World Health Organization is that there are huge divides in the society, and so getting at the distribution, getting at measures that get at distribution or stratification are really important. And so measures that move towards that, I certainly support. Do we need more studies? Yes, we need more studies to test these existing measures. I also alluded to in one of the slides that to get at social determinants, it actually would be a very expensive study, because if you think of that it happens in the life course, it happens from the moment a child is born, and you need these longitudinal studies that follow individuals, again, across time and space, and that's pretty expensive.
It looks as if there are no more questions, so thank you so much for joining us. Please join us next time on Thursday, April 18th, when we continue the conversation with Dr. Jonathan Fielding, who will talk about opportunity costs of current health expenditures in the United States. If you missed any of our previous webinars or parts of today's webinar, go to the Fielding School of Public Health's website, th.ucla.edu. They are all archived there. Please allow a few days for this one to post. Thank you so much, and have a great rest of the day.
Thank you.